Welcome back. This is a patient operated today. A 30 years old female came with a recurrent SINONASAL polyposis involving both the nasal cavity, and she was operated 2 years back at Nellore and now presented with nose block, frequent cold and headaches. So the coronal picture here shows you complete opacification of right frontal sinus, bilateral ethmoids with osteometal unit block with maxillary disease both sides. She also has involvement of the sphenoid sinus, and if you watch it little closely, there is also some hyperdense lesions within this mucosal thickening. Probably we are dealing with sinonasal polyposis with superadded fungal disease. This is the patient's left side, where you can see the post-op changes. The turbinate has been completely trimmed off previous surgery. And you could see the polyps medial to the middle turbinate. As usual, infiltration was given with 2% xylocaine with adrenaline, 10 drops. Nose is being packed again to gain additional decongestion. See the polyps medial to middle turbinate, and with the backbiting, I'm just trying to widen the middle meatus, which was already done in the previous surgery. And with the shaver, it is being widened. The middle turbinate or the middle meatal antrostomy done. The upper half of the uncinate debrided. It's a revision case. Usually you find the bone to be little thick because of the neo-osteogenesis. You'll find the bone little bit thicker and stronger. Now just opening the bulla. And this patient was given a course of steroids even before the surgery, and we give it at least for a week to 10 days time. Usually it is prednisolone or vizolone 10 mg tablet, initially for 3 times a day, then taper it for twice a day, and once a day. Nearly it is given for a period of 9 days. Thereby it shrinks the polyps, and also it keeps the field neat while during the surgery. and less amount of bleeding, and you don't encounter much of post-op complications too. So that is the advantage of giving the steroids. So it is always good to give the course of steroids during this sort of revision cases where you expect a lot of bleeding and mucosal bleeding and all those stuff. And now I debrided the polyp that was medial to the middle turbinate and entering into the sphenoid sinus. As we expected, I could see some fungal debris and fungal thick mucin inside the sinus. I'm just widening the margin of the sphenoid sinus. Just be gentle, don't go deep into the sinus cavity. Just work at the margins. Yeah, now you can see the thick fungal mucin. I'm finding it difficult to suck it out. It was so thick and tenacious. See that? Hope you can appreciate the fungus inside, fungal debris, and the thick mucin. Just giving a saline wash into the sinus cavity, and usually that helps in removing or delivering all this thick fungus that is hidden inside the cavity, and it eases the job. See that? I was able to easily suck it out. Thick fungus that was there. Routinely we send them for the fungal culture and also fungal stain, and one part of it goes for biopsy. So you have to separate it, give it in containers with saline and one container with the formalin. So still I could see some fungal elements attaching to the medial aspect. Here actually the sphenoidal separation, the septum was actually eroded, and we could see the sphenoid on the opposite side also, because the partition has been eroded by the disease per se. You see the thick mucin, and was slowly able to deliver it out. Very thick. So take your time, and sometimes it needs patience. See the fungus has been removed from this sphenoid. Thank you for watching.